afternoon, everybody. This is Dr. Shu with Neuro, and to echo all the other section chiefs, thank you so much for your submissions. This is the one that I selected to best illustrate route path for this course. This is a 14-year-old male presented with an enlarging mass under the tongue and jaw, kind of slightly eccentric to the left. So as they often do in children, with something relatively superficial, they started with an ultrasound. They placed the probe underneath where's my cursor here? Um, underneath the chin and ultrasounded upwards into the floor of the mouth and saw this cystic lesion with kind of uniform low echoes and no internal vascularity. And that corresponded to the palpable abnormality. So they followed this with an MRI. Oops, right here. We have a sagittal T1, axial T2 with fat sat, and axial post-contrast with fat sat. And if you were to see this, how would you describe this in the reading room? Well, it looks like we have a cystic mass. It's a little bit bright on T1, so a little bit proteinaceous. It's non-enhancing, no solid or nodular components to it. I can actually see this muscle being deviated inferiorly. That's the mylohyoid muscle. Mylo means mandible, hyoid bone is back here, and that kind of separates the oral cavity from the submandibular space. So it's bowing down the mylohyoid muscle, and it's bowing upward another muscle at the floor of the mouth called the geniohyoid. Genio means chin. So this cystic lesion, we would say it's located below the geniohyoid and above the mylohyoid at the floor of mouth, slightly eccentric to the left side. Here's a series of coronal images, T1, T2 with fat sat, and post-contrast T1 with fat sat. Again, showing how it's a little bit proteinaceous on T1, a little bit bright, no enhancement, no solid or nodular components, and bright on T2. The most common cystic lesion that we see in the floor of the mouth will probably be the ranula due to a mucocele of the sublingual gland. However, this is a bit larger than we normally see with a ranula and a bit more midline. The ranulas tend to be more lateral, and often by the time they get to the size, will rupture into the neck, into the submandibular space. So this is a more rare diagnosis that you could actually go your entire career potentially without seeing. These are the axial DWI and ADC images. In this case, you can see how it's bright on DWI and dark on ADC, corresponding to viscous fluid, restricted diffusion of water molecules. Beautiful kind of gross images in this case. On the left is an intra-op. Because it was located beneath the geniohyoid, it went for an extra-oral approach. So rather than resecting it from inside the oral cavity, it went underneath the chin, kind of a submandibular approach to deliver this cystic mass. You can see is 6 centimeters in size, pretty large. Now, I've made a note up here that this is actually an ectodermal cyst. So it's lined by ectoderm. And while it's not very commonly found in this location, that's a rare place. This is one of the places where these ectodermal cysts can happen. And the theory is that if you entrap surface ectoderm, when the first and second branchial arches are fusing early in gestation, then you can entrap some of that surface ectoderm that will go on to develop into skin like tissue. And the reason why it happens at the forward mouth is because it's a fusion site for the first and second branchial arches. Sorry, that was not very eloquent of me. And here's the histopathology to go with that. This looks just like skin. It's keratinized, stratified squamous epithelium. Here's the lining of the cyst, and the lining of the cyst is forming keratin flakes, just like the surface of your skin does. And it's sloughing off all those keratin flakes into the center of the cyst. So that mildly proteinaceous fluid, the restricted diffusion in the middle of the cyst that I showed you earlier, it's just a bunch of keratin debris, keratin flakes. So this is an epidermoid cyst. And we've talked about this a lot in the neuro course in various locations. This is an article talking about rare epidermoid cysts in the floor of the mouth. You can see down here in the abstract it says it accounts for less than 0.01% of all oral cavity cysts. And they go on to show a case that looks very similar to ours. The ultrasound looks similar. The MR images look similar. There are some differences. The case I submitted by this resident was more prognathous, was brighter on T1 and darker on ADC. And here's a chart showing various locations where you can see these floor of mouth epidermoid cysts. You can find them below the mylohyoid, in which case they're really, strictly speaking, not in the oral cavity anymore. They're in the submandibular space. You can find them above both the geniohyoid and mylohyoid. When it's located there, they'll usually take an intraoral approach to excision. And then this is what we see in our case, and also the case from this article. This one is located between the geniohyoid and mylohyoid muscles at the floor of mouth. So this was a nice example with great rat path correlation of an epidermoid cyst, the floor of the mouth, submitted by Dr. John Adams. Thank you.